Welcome to the program. I'm your host, Neil Howard, here on Health Professional Radio, and thank you so much for joining us again. I'm going to be speaking this morning with Dr. Alan Burton, Medical Director at Abbott Neuromodulation, and he's joining us on the program to discuss the DISTINCT trial. It's going to investigate the effectiveness of Abbott's BurstDR. Welcome to the program, Dr. Alan Burton. Thanks for taking the time.
Thank you, Neil. It's a pleasure to be with you this morning. I really appreciate your time and your interest in our DISTINCT clinical trial.
Give us a brief look at your background, and then let's talk about what the DISTINCT trial is.
Yes, my background, I've been with Abbott now going on about 5 years, and I'm a anesthesiology interventional pain specialist. I was in practice for about 20 years, both in academics and private practice, in treating patients with chronic intractable pain syndromes of a variety of different causes. A lot of that is back pain, which will become important in our later conversation this morning. And then over the last 5 years, I've joined Abbott in the role of a medical director to help with study design and all sorts of interesting aspects of these chronic pain therapies.
You mentioned back pain. Are we talking any type of back pain?
Yeah, it's a great question, Neil. When we think about back pain, first of all, there's an incredible number of people in the U.S. and really in the world that suffer from chronic intractable back pain. And when we think about our therapy, it's really important to understand that about 30 million Americans experience low back pain at any given time, low back pain being the most common of that. And while these patients are evaluated often by either their primary care physician or surgical specialists, only a subset of these patients have a really identifiable treatable cause and are surgical candidates. So it ends up that a large percentage of these patients end up not having a surgically treatable reason for having this intractable refractory back pain. And a lot of it we call neuropathic back pain, where the nerves themselves become very irritated and a part of the problem. And in the absence of a surgically correctable condition, a lot of these patients then meander into certain types of conservative care treatments, some of which are fairly well understood, things like physical therapy and massage and other types of treatments. And some of those end up being ineffective for these patients. So there ends up being a large group of these patients out there who end up with ongoing chronic back pain that's persistent and quite bothersome. So these are really the patients that we're trying to focus on in the DISTINCT study.
Now, are we talking about patients that had some success with other treatments and then those treatments gradually became ineffective, or they had no treatment whatsoever or had no success with any treatment whatsoever before?
Yeah, I think that's a really important and very, very kind of detailed question about these patients, Neil. I think it's both subsets of patients. There are patients who begin to experience back pain, and it just becomes relentless and really difficult to live with, and never shows any improvement at all. And that's kind of one group of patients. And then they're frustrated because they don't have a clear pathway toward relief. They don't have a surgically correctable problem. And then another group of patients might have a smoldering course or a stutter step where they get a little bit of improvement with, say, an injection or with, say, physical therapy or chiropractic, and then they have a setback. And oftentimes this is kind of a stair-stepping downward trajectory where gradually over several years, the pain gradually gets worse and worse. And again, they're not in that group where they go to the doctor, get a diagnosis, and get a treatment that's effective. They get in this kind of downward spiral where gradually over several years, the pain gets worse and worse. And I think both of those groups are really important for us to really focus on and try to identify a really evidence-based way to treat those patients.
So what is the DISTINCT trial, and how is it going to affect those patients?
So the DISTINCT trial that's an acronym. You know, a lot of these clinical trials come up with a clever name, and DISTINCT is kind of a variety of words called dorsal spinal cord stimulation versus medical management for the treatment of low back pain. And so then we push some of those letters together and call it the DISTINCT study. So this is sponsored by Abbott using a proven therapy that we've used now for several years in U.S. and worldwide to treat other chronic pain syndromes. It's called BurstDR neurostimulation, where there's a small pacemaker-like device that's trialed, and then, if effective, it's implanted into the patient with some wires into the spinal area, as well as a small battery that's under the skin. this pulsatile electrical energy has an effect on the nervous system of quieting those pain signals, and not only quieting the pain signals as they travel to the brain and in the brain, but also quieting the emotional distress that often accompanies chronic pain. So the patients get their pain brought down to a tolerable level, and they get an improvement in their overall health status. And we've shown this across a variety of conditions, really, again, U.S. and worldwide, where this device is already in use. It's FDA approved. It's approved by Medicare, other commercial insurance companies for a variety of diagnoses. Typically, in back pain, we've held this therapy for those patients that have had previous surgery and are now seeking other options where the surgery has not been successful or where they've had repeated surgeries with a poor outcome. We've really held it in our back pocket for those patients. What we're looking at now is bringing it to patients who are not candidates for surgical corrective approaches. So that's kind of the nuanced difference with this therapy.
Now, I understand that there is someone currently enrolled in the DISTINCT trial. Are there others?
That's right. Yeah, the study has kicked off. We're very excited about it. And the first, now there's been more than one patient enrolled. We had to reschedule interviews. So I think now there's maybe as many as 5 patients enrolled in the DISTINCT trial. I don't have the data count as of this week, but the study's ongoing. It's what we call a prospective multi-center randomized controlled clinical trial. And so what that does, it's a very large trial, and that's really important when we try to gather evidence to show the effectiveness of a treatment. This trial will ultimately enroll 270 subjects at 30 sites across the U.S., and then those patients, when they get into a clinical study, this is different than just having a therapeutic encounter with a physician who recommends a treatment. The patient will be identified as a candidate for this trial, and then they undergo what's called randomization in a clinical study. And what that means is there's a computer-generated coin flip, if you will, that puts the patient either into a conservative care arm or into receiving the BurstDR therapy arm. And then those groups go forward. And then following 6 months of treatment, either with ongoing measures at conservative care or with the BurstDR, then the groups are compared to see how effective is the BurstDR therapy compared to the arm that's getting the conservative medical management. And then that 6-month outcome becomes a really important bit of what we call evidence. And we talk about evidence-based medicine or getting treatments that are proven to work or shown to work. And this is really important when physicians have discussions with patients, and also when insurance companies look at covering these kind of therapies. Everybody wants to know that they're clinically effective. So this is how we and understand the effectiveness of these therapies.
Now, just to be clear, when you say ineligible for surgery because the condition is deemed not bad enough for surgery or inoperable?
Yeah, that's a really good question, Neil. So what we're trying to do is offer a therapeutic option for patients who don't have a surgical treatment approach that's identifiable. And what the bulk of these patients will be will not have an identifiable source for their pain, which means that they may have 2 or 3, there's 33 discs in the back, for example. They may have 2 or 3 or 4 degenerative discs, but they have intense pain in one location. And the surgeon can't really determine a specific narrowing or one specific location to operate on in the back. So there are a lot of patients in this bucket where the surgeon looks at them and understands that they have a back problem, they have pain, but there's no identifiable surgery to help with one area. There's a smaller group of patients who get an evaluation with a surgeon who says, oh, okay, you have a narrowing in at this level in the spine. That's where your pain is located. When we correct this, we can expect your pain to improve. That's those, you might say it's there's lucky or unlucky. I don't know if nobody really wants to have back surgery, but at least those patients feel like their cause of pain is identified, and then they have a clear path toward, fixing that. Whereas there's much larger group who get X-rays and MRIs and evaluations, and the surgeons kind of shrug their shoulders and say, we're not really sure what to operate on. So your outcomes would be very, poor with surgery, and we wouldn't really even know what surgery to recommend. But it doesn't make their pain any less severe. It just means it's not really eligible for surgical. Kind of clarify that statement.
Well, where can our listeners get some more information about the trial and about Abbott?
We have a nice website at Abbott.com, and there's links within that will direct them into the right therapy for their condition. In this instance would be chronic pain and neuromodulation therapies.
Well, I appreciate you joining us here on the program, Dr. Burton. Thank you so much.
Oh, it's been a great pleasure to talk this morning, and really appreciate your interest in this topic, Neil.
You've been listening to Health Professional Radio. I'm your host, Neil Howard, in conversation with Dr. Alan Burton, Medical Director at Abbott Neuromodulation. Audio copies of this program are available at hpr.fm and healthprofessionalradio.com.au. You can also subscribe to the podcast on iTunes. Listen in, download at SoundCloud, and be sure to subscribe to our YouTube channel at youtube.com, Health Professional Radio.